Afternoon to everyone and welcome. Thank you for joining us today for the Impact of COVID-19 on TB Services webinar. My name is Patty Woods and I'm a public health nurse consultant for the New Jersey Department of Health. But before we get started today's presentation, I'd like to run through a few housekeeping items. Today's presentation topics will include programmatic adjustments in Virginia using COVID-19, changes in clinical care and community work in New York City, and TB control activities during COVID-19. And I guess it would help if I advance my slides. All right, bear with me. This is my first remote webinar. As I'm sure as everybody's getting used to these days. All right, so let's talk a little bit about the audio. Please remain muted throughout the webinar. Do not put your phone on hold because this is going to disrupt the webinar and we will have to remove you from the webinar. And we do not want to do that. Okay. Questions. We will have time for questions at the end. Please type your questions at the chat box, which is located in the bottom right panel. So if you look down on the bottom of your right-hand screen, you should see chat, and that's how we can communicate and ask some questions and have some good discussion today. We have a sign-in sheet and evaluation. If you're viewing with the group, please complete the sign-in sheet and return it by email to Shweta, and that's your email address. And at the conclusion of today's program, you will receive the link to an evaluation. Please share the link with others if you're viewing as a group. And please do fill out the evaluation because we do look at them and we would like to know future topics and what we can get better at next time. It's a real help. So there is a live event help desk. If you experience any technical difficulties with this webinar, please contact WebEx directly for assistance. If you have a pen, just jot down this number, or you can Google this help WebEx. And our faculty today is going to be Amanda Khalil, Dr. Joseph Rosinski, and Mark Wallman. And I am very pleased to announce our very first speaker for today. And I'm going to turn the microphone over to Amanda Khalil. Sorry. And let me just tell you a little bit about Amanda. She is one of the 2 Virginia TB nurse consultants and has worked with the Department of Health since 2015. Amanda works closely with the local Virginia TB programs through providing TB guidance, technical assistance, training, and program evaluations. So Amanda, I'm going to turn this over to you and we'll get started.
Thanks so much, Patty. Can you hear me okay?
Fine, I can hear you fine.
Okay, great. So hi, everyone. Thank you so much for joining the call. And I thought I'd start out with a poll question. And I think we probably know the answer to this already, but is your TB program seeing any decreases in the number of TB cases? So if you can just respond, we'll leave that open for just a second.
So, Amanda, I posted the poll,
okay,
and we have about 25 people who said yes, 6 people who said no, and 11 people who said unsure.
Okay, so I think that's probably in line with most of the TB programs around the U.S. that I have been kind of chatting with, that we are seeing a really big decrease in our reported TB cases during this pandemic. So I want to talk a little bit about what we did in Virginia for our TB programs, the recommendations that we provided to them during this time period. We knew that our staffing was going to be very limited. We knew that we needed to limit our contact with our patients. And so the Virginia Department of Health worked with each specific clinical program to pull together guidance and produced it as one big guidance document for our local health departments. So I worked on pulling together the TB program recommendations with my fellow counterparts in our program. And so one of our main recommendations was really to transition as many people as we could onto what we call in Virginia video enhanced therapy. So we call it VET, but basically that's our telehealth. We have a platform called Doxy.me that we use, and we started to roll this out majorly to all of our programs and enroll as many of our clients on this platform as possible. In the past, we've had pretty strict recommendations for who can be placed on VET, and we really kind of threw those out the window and said, anybody we can sign up, let's sign up. So we encourage the expanded use of VET for both DOT, directly observed therapy, as well as for monthly clinical assessments for clients that our treating TB clinicians deemed were stable enough to have kind of a telehealth visit, didn't need to be seen in person or have like monthly blood work or vitals done. So we did try to provide some scales and some equipment to some of our patients, but that was also limited. We didn't have a lot of that on hand prior to the pandemic. You know, a nurse would use one scale and measure everybody. One of our other recommendations was to start mailing medication to our clients directly from our central pharmacy. We have a central pharmacy in Virginia, so we worked very closely with them to work this out. We actually have individual pill packs for our active TB cases where the medicines are packaged in one pack of all their pills for that single day, and we started mailing those meds straight to their homes. We encouraged our TB programs to stop providing TB screening for testing, for school and work. This is a service that we deemed kind of non-essential at the time because so much of our staff was being pulled. We also produced guidance on PPE, so what personal protective equipment our staff needed to wear for certain situations. And of course, there were lots of different situations. So we provided that guidance for each situation, which also included symptom screening of our clients, when to do that and how to do that. We encouraged our programs to postpone LTBI starts unless the clients were high risk. We also encouraged our departments to switch from using the tuberculin skin tests over to the blood test, the IGRAs, in order to decrease any in-person contact that we had to have with clients. And, you know, after we made all of these recommendations, we've been reflecting on how our program is actually going to change down the road, which is perhaps something we will talk about later in this webinar. But we really focused on trying to narrow down our essential services. We needed to support our active TB clients, but we also knew that we had to balance a lot of the restrictions that were being placed on our health departments in general and protect the safety of not only our staff, but our patients. So Patty, I'll turn it back over to you.
Thank you, Amanda, and I'm sure we'll have a lot of questions. I know I do at the end of this presentations. So now I'd like to take the time to introduce Dr. Joseph Brzezinski. Dr. Joseph Brzezinski is the Assistant Commissioner of New York City Department of Health and Mental Hygiene and Bureau of Tuberculosis Control. And welcome, Dr. Brzezinski, and it's we'll turn it over to you. Dr. Brzezinski, are you there? I'm not hearing you.
think you're muted, Dr. Brzezinski.
I can't hear anything. Can anyone else hear?
No, I think he's actually muted, so maybe we'll just go over Mark's slides, and then we'll come back to Dr. Brzezinski.
Okay. Yeah, it says audio conference muted. Okay. All right. Until we get this technical difficulty resolved, we're going to just move on to the next speaker right now. And, you know, of course, this remote stuff is a challenge for everybody, so we're doing the best we can. But I will introduce Mark Wallman. He is the Program Manager of TB Control at the Global TB Institute. And I'm sure a lot of you know Mark for a lot of his contact investigation activities. So, Mark, are you on?
Yes, I am. Can you hear me, Patty?
Yes.
All right. Well, thank you very much, Patty, and hi, everybody. So, as Patty mentioned, I was asked to briefly comment on 3 components of our local program that have been adversely impacted by COVID-19 by discussing any noticeable changes in how we conduct large-scale investigations, TB interviewing and contact tracing, and field work. First, I know I have only a few minutes here, but I went back a year to take a look at the number of cases reported in our clinic. So I took a look at March 15th through May 15th, 2019. In our clinic, we reported 13 cases and 5 large-scale investigations. Fast forward to this past March 15th to May 15th, we only had 4 cases reported and 2 large-scale investigations. And this is coming from a clinic where we average about 18 to 21 large-scale investigations per year. So based on the poll that we saw, other programs are experiencing a lower rate of reporting cases. So the question is, where are the TB patients? Well, we know they're out there, but either they're not willing to seek medical care in hospitals or EDs or private doctors for fear of the virus, or they are visiting medical facilities. But since TB symptoms mirror some of the symptoms of COVID-19, the focus of healthcare workers is to test for COVID-19. If the test is negative, the patient is discharged without or rule out TB, no sputum, no x-ray. So we anticipate, we are guessing that over the next several months into the fall, we should probably be seeing a surge in TB patients locally and nationally. So taking a look at large-scale investigations or congregate setting investigations, which we know are divided into 2 components, the management meeting and the on-site assessment of potential exposure environment. It's highly recommended we do these in person, not over telephone. However, we have decided to avoid personal visits during this time period and use WebEx and or the telephone for the management meeting. Fortunately, as I just mentioned, we only had 2 large-scale investigations during the last 2 months. So the first case, we utilized WebEx for the management meeting. Since the index case was a caregiver with 2 other coworkers in a residential setting for 4 disabled adults, I considered this more of a household investigation, so there was no need to do an on-site or no need to do a WebEx or Zoom meeting for the exposure environment. So I considered it household. We tested all 6 individuals. They were negative on initial testing, and post-exposure testing is scheduled for this week or early next week. The second large-scale investigation involved a high school. Despite the school closure, I was able to contact the superintendent of schools because I know her from previous investigations. We discussed the case over the telephone. I requested class rosters of the student in question and was able to determine, based on duplication of classes and hours of exposure during the infectious period, I was able to put together a list of students and teachers requiring testing. So these aren't ideal ways to conduct investigations, but in this particular high school investigation, you really need to see the classrooms, but under the circumstances, we need to be flexible and bend the rules. Regarding TB interviewing and contact tracing, since most of our cases are reported by local hospitals, It is our standard of practice to initiate the TB interview while the patient is currently hospitalized. But we decided not to visit hospitals during this time period, and as we know, hospitals discourage visits from visitors. And so instead, we conducted the interview over the telephone and/or FaceTime. Again, not the preferred method to conduct an interview over the telephone, but this was temporary. We had to make the changes to our standard of practice. Regarding contact tracing and testing, that was also adversely affected by the COVID-19 because operationally, our clinic hours were greatly reduced. And so while all contacts are a priority, we further prioritized according to level of infectious in this case, the hours and environment of exposure and any additional risk factors of the contacts if known. And in closing, a word about fieldwork. All routine fieldwork was likewise suspended during this time period. Instead, field visits were replaced with letters and telephone calls to the patients to schedule future appointments, also done through FaceTime. I wasn't happy with it because, as we know, there's nothing like this in the impact of a personal visit. But we had to make changes to our standard of practice. All cases were placed on video DOT, and were given a 2-month supply of meds back in March. And so they are due for a refill this month, and they'll be given another probably a month or two of medication so that we can monitor them through the video DOT. So having said that, I'll turn it back to Patty.
Okay, Mark, I think we do have a polling question, but I guess we can do that at the end.
I think can you hear me now, Patty?
Yes. Mm-hmm.
I found my mute button.
Okay, great. So now we will switch over to Dr. Brzezinski's presentation. Thank you.
All right, so thank you. Hello, everybody. Much like the previous two speakers, we have changed our services quite a bit, quite drastically. And we had to do it very quickly, of course. We normally run 3 clinics every day in New York City, so we have a total of 4 across the city. 2 of them are part-time. That's why we have 3 open on every day. And when there was an announcement from the governor that we were going to, much of the city was going to be shutting down, we decided to close 2 of our clinics and just maintain 1 open every day. I think we've been really lucky to have that 1 clinic open every day because we have about 860 TB cases in New York City every year. We manage about half of those ourselves through the health department clinics. And without being able to keep 1 open, it would have been very difficult. We found, even though we've really moved to a model where we've changed to telemedicine, we're communicating with our patients remotely, still find 5 to 10% of our patients really need to come into the clinic for either a blood draw or some close evaluation by a physician or a nurse. So telehealth program is something that we've really jumped right into. We had been doing we've been doing video DOT in New York City for many years. So it was easy to get all of our patients on video DOT, but the actual health visits were more difficult. We had started a pilot program of doing telehealth for patients receiving treatment for a latent TB infection during their follow-up. So we had a little bit of experience, but in mid-March we had to jump feet first, full force into telehealth for all of our patients. We're using 2 platforms that have been approved by the IT department at the Department of Health. So we've been using FaceTime and Skype for Business. And when we can't set up one of those platforms, we'll just communicate by telephone, although that's not the preferred situation. And of course, we've had some patients who've had difficult management problems, but either for a variety of reasons have not been able to come into our one clinic that's open. So we have been doing some home visits. We call the home ahead of time to make sure that there's nobody sick in the home. We try to keep the visits limited, the number of people going into the home. We wear the appropriate PPE, but I think that that's been done fairly successfully. As far as disease investigation and case management, we've moved all of this work to being done remotely. Our standard before the COVID pandemic was to go to the hospital for most patients to do an initial interview, collect the medical information. We're doing all that remotely. Almost our entire staff is working remotely, and so that's how we're conducting our field work. I would have to say a lot of things that we used to do, we're not able to do now. We routinely make home assessments to see what the home environment's like, to see if we can learn about contacts. We do testing of contacts at home, but we have not been able to do that for the last 2 months. And really all of our large-scale congregate setting investigations have been put on hold. I would say, the staffing issues have really impacted us. At least half of our staff are working as part of the emergency response, within the ICS structure. So a lot of our staff are not working in TB control right now. So we're trying to keep it together with the staff that we do have. And then those staff are largely working remotely and doing their work over the phone and through the computer. So it has, I think we've done a pretty good job. I think we're able to take care of our core issues. I don't think that this could go on indefinitely. There's definitely going to be things that we're not picking up quite as thoroughly as we do in our routine work, but I think we've been able to accomplish our core work over the last couple of months, and hopefully things will start to normalize in the coming weeks and months. So that's it for me. Thanks.
Thank you. Thank you. So those are all great points, and I think we do have a poll question here, but we're getting ready to do our discussion too. So if you do have any chats, if you have any questions, please just type them in the chat. But now we'll switch to our poll question. Is your program still providing in-person DOT for MDR or other high-risk patients? Yes, but with the appropriate infection control precautions, or no? And Tretta, I can't see the results, so whenever you want to close the poll, that's fine.
Patty, I've closed the polling, so we have about 25 people who answered yes and 10 who said no.
Okay, so, but yeah, that's another challenge, because the more difficult cases, how do we get them in and get them seen? And is it no because you don't have them, or is it no because you just don't have the ability to see them? And then what are we doing with those particular patients? I'm just going to go through really quickly, because I think we had another polling question that we might have missed. Okay, We do have one more polling question, and this was to follow up for Mark's, and if you can just bring that up. And how is your program currently conducting TB interviews for contact investigations? So we had some of our speakers give some of the things that they were doing, and we'd like to also hear what is going on out there. So are people using conferencing telehealth? Are people going to on-site visits? Or are you using the telephone? And I guess the other one could be we're just putting them on hold altogether. But let's see what our poll says, and then we're going to get to some chats, because I do have some questions, and hopefully some others would like to share what they're doing out there too in our discussion.
All right, Patty, close the polling. So we have 7 participants answered using video conferencing, 4 on-site visits, and 27 answered through telephone.
Okay, great. Thank you, Shweta. Yeah, that's something that when this first came about, using like Dr. Brzezinski was saying, like using doing telemedicine and on-site, all this technology, it was out there, but did we feel comfortable using it? So that's fine. We go back right to the telephone to get these contacts and people notified for what they have to do. And I'm just going to go back over here to see if we have anybody that has a chat question. And I do have a few questions. Let's see. We have a question. We currently do not have any MDR cases, so that's very good that you're not seeing them because you don't have any, so that's a plus. Are any persons being placed on LTBI treatment, and if so, how are they getting the medication? So for our speakers out there, is anyone being placed on LTBI treatment, and if so, how are they getting the medication? And Amanda, you were saying you were mailing medication. Does that include LTBI, or is that just cases?
Very rarely are we mailing medications for LTBI clients. It has to do somewhat with, we haven't really confirmed addresses. We don't often do home visits with our LTBI cases. We do want to make sure we've had a good look at our LTBI cases before we just start them on treatment. So in Virginia, we're really only starting people who are high risk. Most likely they've been a contact to a case that we're working on. Otherwise, we are delaying LTBI starts. They are either coming to the health department to pick up that medication through kind of these new protocols to enter the health department, symptom screening, going into not really waiting in the waiting room, symptom checks at the door. So there's a whole variety of things that go into that. And some of them are also getting medication taken to the home if there are nurses who are still working and doing some home visits. So it's definitely a variety of ways in Virginia.
I think, yeah, we're just kind of like, coming up with some things as we go along. I know some of the clinics here in New Jersey have limited what the patients, every clinic kind of does it a little differently, but limited the amount of patients that will come in, and of course continue with the ones that have already started, maybe give them a 2-month supply. And again, that's the other thing that someone had asked, and maybe others out there can also chime in. But when you're doing these checks, a lot of the clinics, for LTBI checks, not necessarily TB case checks, but it's kind of like come in, hi, take a quick look over and give them their meds, where before they would have a little bit longer conversation or maybe get some vitals and weights and stuff. But right now they're just kind of doing a visual, and I was wondering if that's kind of the same out there, or you're doing it via video. Someone did say LTBI are still coming in monthly for meds, but interview over the phone. And then, yeah, that's right. They just kind of come in with their mask, get their meds in, and keep going.
Patty, I will also say that we have okayed people getting a 2-month supply of medication for LTBI if they are getting those LTBI meds.
Thank you. Someone was asking about Doxy.me. Is one of the platforms they're using for telemedicine video visits. What other platforms are you using? Any specific challenges or disadvantages you have noticed with particular platforms for the doctor or the nurse? And Amanda, I know you're using Doxy.me, and Dr. Berinsky, do you know what they're using, what kind of telemedicine you're using in New York? What you're using for telehealth?
We are in New York. In New York, we're using FaceTime and Skype for Business. This Doxy.me sounds great. For us to use it, we have to have approval from our IT department, and we don't have approval yet, but we're looking into being able to use it because it sounds like it's a very easy to use, user-friendly platform. One of the big issues for us in all of these platforms is many of our patients do not speak English as a primary language, and so we need interpretation services. And looping the interpretation service into the platform has been a challenge.
Thank you. And Amanda, do you see any challenges with the Doxy.me that you notice?
So one of our biggest challenges in Virginia is the fact that we have quite a few rural areas in the state that don't have a lot of good internet access. And so we have had some of our health departments out in the southwest portion of our state that simply cannot use telehealth options, just is not working for them. We've also seen clients who don't have smartphones and so, can't access our platforms in general. We've seen that Medicaid is issuing some clients these track phones, but they have very limited data, and most of them I don't even think can do, a telehealth visit. So that's actually been, I think, our biggest challenge. But we also have an aging workforce. So this has been a big lift for some of our nurses to get comfortable with our Doxy.me. Like I said, we were using this prior to COVID-19, but now we're using it widely and almost every nurse knows how to do it. And so that was a big lift for us at the very beginning.
Yeah, that's a really good point because we always think about the challenges from our patients, but there could be internal challenges as well. And I think having been forced into this technology world because of the COVID, I think we will see a lot of changes because I guess people kind of forced to get this technology on board. And, I guess once we're starting to use it, we'll see, how comfortable people feel about this. And do you think going forward it's something that you're going to maintain because of this experience? I have a question, and maybe Mark, you can answer this question. I just had a thought, like you were saying, you can't go to the congregate settings, but I'm not sure if anybody has done this, and if you have, let us know about it. But it was just a thought I had. Obviously, you can't go to the schools because the schools were closed, right, to see the classroom. But if you did have an opportunity where maybe it was a healthcare setting, but it was really not recommended for anybody to go in, or nobody could go in, would you feel comfortable if, say, one of the staff members kind of did maybe like a FaceTime and kind of gave you an overlook of the facility via a picture or via a video? And do you think how that would work? And has anybody done that? I'm not sure. Have you done that? Maybe you did.
So actually, in the first investigation I cited of the residential setting, the director of nursing of this facility said, well, I could bring my laptop to the house. I'll put you on WebEx or Zoom, and I'll walk around the laptop and show you the house. But it really wasn't necessary. But if it was I think it's rather awkward to do that. I think that you really can't get a good sense. I mean, something's better than nothing, but I'm not sure whether you can get a good sense of an environment of exposure. Like for me and for others, perhaps, I like to go to the site. I take measurements. I draw diagrams of the rooms. I get it. There's nothing like standing in a room and getting a sense of what the ventilation is like and what the what the environment is like. So, going through these video conferencing platforms, it's helpful to some extent. I did have an investigation recently, or prior to March actually, of exposure in a dialysis unit, and right before we stopped making field visits, I did make a site visit. I did what I had to do. I walked through the environment. I saw all the where the patients take their where they have their treatments. And however, soon after March 15th, I wanted to go back, and the facility really didn't want me to come back. They discouraged visitors from coming back, even wearing a facial covering. So it concerns me because I want to have these few people tested. Now that the contacts who are identified, they're afraid to come to our clinic. They're afraid to go outside and do unnecessary trips to a clinic or a private doctor because of the virus. So these high-risk individuals have not been tested yet. And I've called the facility several times, and they just said that they don't want to be tested yet. Now, in New Jersey, we can take legal action, as you know, Patty, on contacts who, quote unquote, are refusing to be tested, but I will not do that now. I need to respect the fact that people are fearful to go out, and we just put them on a pending file, and come June or July, hopefully we can get these types of high-risk patients tested. So I wouldn't push myself on a site. If someone would allow me to come in, I would consider doing it as long as I was obviously masked and everybody else was masked. But right now, I guess I never thought I'd say we're fortunate. We only had 2 large-scale investigations to do in the last 2 months, which is very unusual for us. So, but I think the key here is that just like every patient, every case, every Congress setting is unique, and they have to be approached in their own uniqueness. And sometimes we can get away with a video conference or a telephone call, and sometimes we may feel the urge to, no, I really got to go, and I really got to see this place. But so far that hasn't happened, and I'll just make that decision as we move along.
Yeah. Hi, Lisa. Lisa in California said they heard programs using FaceTime in the home setting to see this, but probably not ideal for work sites as well. And there's someone else, Cheryl, is going into the congregate settings using the full PPE gear, and that's great if they will let you in or if they're still open. And I guess we're just trying to figure this out as we go along. And Mark, yeah, you're right. I know there's sometimes you have like these really big concerns about patients you want to get right away, but this is like, now what do we do with them? And I guess we just prioritize them when we can get them in. But
Right.
That is a good point. That brings me back to another point: is what do we do? Like, how are we finding? What do we do with these vulnerable populations in the home? Or how do we know there's not a vulnerable population in the home? Or we just have you come across any or anybody, any of the speakers out there? Let me know, or any in the audience as well.
I think our programs in Virginia are still working hard to at least get into the home, once and see who all's there, and still testing really those high-risk folks in the home.
Yeah.
In New York City, we have not gone into the homes for over 2 months. We've stopped all home assessments and any contact tracing in the homes. So it's been very, very limited. Maybe, of course, the COVID epidemic's been worse here than anywhere else, but so we've been very, very cautious about going into anyone's home for the protection of our staff, especially.
Yeah, I think that's.
I'm sorry. I agree, Doctor. In our clinic in New Jersey, as I mentioned earlier, we suspended all routine field visits, only if it's something that was really urgent. But the field staff has not conducted the routine field visits as they used to, or as they're accustomed to, I should say.
Yeah, and I think that's a really good point, and it's important to look, because we have callers on here from all over, and I guess it really depends, where your TB cases are and what's the incidence of COVID in that area. So we'd have to, adopt different policies for different things. But I also had someone that asked, I have another comment about, and Mark, you could ask, or anybody could comment how they, or if they're doing this, they might obtain a floor plan and have someone who works there and able to do so and get measurements to pass it on. And, that might be really good too, some of these things for the initial, and then maybe you go back later on. But would you consider anything like that initially until you could get in there, maybe?
Yeah, I think it's a good idea. I think any information we can get from another source that would be helpful would be a good idea. But for me, it's like I can look at a floor plan and I can look at the measurements, but there's nothing like standing in that environment and seeing for yourself, the closest of desks or whatever, my workstations, what was the ceiling height, was there ventilation? But I think short of that, I think if we can collect information from another source, I think it certainly is not, I think it's a good idea. But I think the site visit is really critical in making a determination of where the potential exposure or transmission may have occurred, depending on the environment itself, the physical layout.
Okay, thanks. And Lori was saying, like this, we have some curbside or front porch type visits if the client agrees. So I guess that's another option, to gear up and kind of maybe see if we could keep the patient outside so it's a little bit less risky when we're dropping off stuff or trying to do a home visit. I have a question, though.
I think that's a good idea. I think we actually, you just reminded me, we did that last week. One of the field reps did a curbside visit to a patient. I forgot what it was for, but I'm glad you brought that up. We have done that.
Yeah, we're having a lot of these birthday drive-bys here in my neighborhood, so people are driving by and throwing gifts out the window. Maybe we could drive by and throw our TB meds out the window or something. I don't know. Everybody's, I think, just trying to do the best they can to get through this trying time because we've never had to do this before. I do have one last question. We're getting close to the end of this, but so if anybody has any questions, please get them in right now. And if not, I do have one last question to put out there. And this is something we're experiencing here. And again, this might be different depending on what the incidence of COVID is in your area, but what we were finding, and how do you handle this? What we're finding a little bit here is in some areas, especially when we were at the height of this, people didn't want to keep their TB patients in until they were discharging them very quickly. Infectious, didn't matter, or, quickly without us doing our normal protocols of making sure they're not infectious or getting a good home visit to make sure there's no vulnerable population. And I was just wondering if anybody out there had that experience and how you were handling it. With the hospitals being so crowded. On one end, I totally understand where they are and we got to get them out of the hospital, but on the same end, we wanted to protect the population for TB. And I don't know if anybody else was experiencing any of those challenges.
So I can just say from a Virginia perspective that we have always gotten our clients out of the hospital very quickly. And so it hasn't been too much of a change for us here. We usually try to leave them in the hospital for as little time as possible and get them back out.
Yeah, I agree. I agree with you too. Everybody has different philosophies and uses different protocols for that. But if they can get them out and we know that they were home safely, I'm an advocate for that. But in this situation, I think they were getting out so fast. In some situations, like the nurses didn't even get to know that there was a case before they were already discharged. And we have a little bit of we can here in New Jersey too, we'd like a little bit of notice, right? So we could do what we got to do. And then someone said they had a patient leave AMA for fear of COVID. Oh, that's a good point. And does anybody think that the decrease in cases is because we're missing cases or cases don't want to go to the hospital because they are afraid of getting COVID in the hospital? Or have anybody actually heard that from any of their patients? And I think that's a thought that's just rolling out there that, if they're not that sick or they're staying home till this is over, till they actually find out what's wrong with them. Anybody have a thought about that or seeing any of that?
Yeah, in New York, our cases are down for the last 2 months, and I feel pretty confident that it is people not wanting to go to the hospital, so or to their doctors, and so I think people who are mildly or moderately sick, just have a chronic cough, but not coughing up blood or anything that's emergent, are just waiting it out. I think I really suspect that that's the reason that our cases are down.
Yeah, I'm seeing that in some of the comments too. Severe side effects needing emergent care have not wanted to seek care due to the fear of COVID, which is a real fear. And again, like Mark was saying, you know, even the contacts, they don't want to come in right now because they're afraid to make that visit to a healthcare setting. Does anybody else have any thoughts or questions? I don't see any more questions in the chat box, and I don't have any other questions, but if our participants or our staff has any other questions, and if not, we're almost time to wrap it up, so we will wrap it up a few minutes early, just so you can go back to double duty, some of you. But before we do that, I would just like to ask again if you can please fill out that evaluation when you get the link if you have any questions. And now that that this is over, and you think of a question later on and you want to answer that question, send it to Shweta and we'll do the best to get that question for you. And please complete and sign in all the sign-in sheets and email them back to us. So I'd really like to thank all our speakers today for their great presentations and their insight into our TB and COVID experiences, and thank our participants for taking the time to have the time to cut out of their day to listen to the webinar. And everybody have a great day, and this concludes today's webinar.
Thank you.
Thank you.
Thank you.
And